Good morning, everyone. I'm Michael McGinnis, Executive Officer of the National Academy of Medicine, and it's my privilege and pleasure to be welcoming all of you to today's meeting on priorities on the health horizon, which is working to inform PCORI's strategic plan. We are very proud to be partnered with the Patient-Centered Outcomes Research Institute in this meeting series. This is the second in the series. You know, we were both created by Congress, the National Academy of Medicine and the Patient-Centered Outcomes Research Institute. The National Academy of Medicine is one of three academies created under the 1863 charter that was passed by Congress, creating the National Academy of Sciences, which has since been joined by the National Academy of Engineering and the National Academy of Medicine. Our role is pretty straightforward under that charter, and that is to serve as advisor to the nation on matters of health, healthcare, and biomedical science. PCORI was similarly created with a passage by Congress of the Affordable Care Act a decade ago, and it was established to improve the evidence base on which clinical decisions can be made. Our legislative experiences, I should mention, were slightly different. The National Academy of Sciences Charter in 1863 was drafted, introduced, passed, and signed by President Lincoln in one day. So it was a fairly streamlined effort. That's a little bit different from the experience of the Affordable Care Act, but nonetheless, the Patient-Centered Outcomes Research Institute was one of the gems that emerged from an extensive legislative debate around the Affordable Care Act. And again, we are very proud to be partnered in that respect. Our commitments are pretty similar, and that is essentially to improve the health of the nation. PCORI really was in many ways created with a view to establishing a new research capacity, one that could be genuinely focused on the needs of patients and their families, one that could be nimble in response to their different and changing circumstances and could take advantage of a growing ability to use new clinical research approaches to provide evidence in real time from the real world, and to foster the development of an infrastructure that was necessary to be able to provide that kind of patient-focused evidence, patient-generated evidence as well, in a means that would accelerate application of broadening of the evidence base and accelerate its application for better care and better health for all Americans. The National Academy of Medicine has partnered quite logically and enthusiastically in this because the NAM's Leadership Consortium for a Value and Science-Driven Health System is focused on ensuring that the infrastructure that's necessary to provide the kind of advances that PCORI is devoted to has the support and the engagement of multiple sector leaders in its construction in order to ensure that the health system as a whole is effective, is efficient, is equitable, and continuous learning. We have been extremely fortunate as well to have as the chair of our meeting, both in the last session and this one, Dr. Neil Poe, who is a National Academy of Medicine member, as well as a a very active participant in the leadership of PCORI and has been a superb contributor in that respect. I'd now like to turn to our partner and leader of the Patient-Centered Outcomes Research Institute, Dr. Nikela Cook, who is the director of the Institute and who is leading PCORI's efforts to ensure that as they look to a new decade and beyond in the development of the capacity of the nation to provide the kind of evidence that's needed to improve the health of Americans, that the strategic plan of PCORI reflects those possibilities. Again, it's been a pleasure working on this, and especially a pleasure working with Dr. Cook. Nikela?
Thank you so much, Dr. McGinnis, and good morning, everyone, and welcome to this second meeting of the Priorities on the Health Horizon convenings. We're really delighted to collaborate with the National Academy of Medicine on these virtual sessions and want to thank all of the participants who've gathered today, as well as our panelists and facilitators for their preparation, as well as what I anticipate will be robust participation in the meeting. We really do value your insights and perspectives on some of the trends and opportunities that can help shape health and healthcare in the years ahead. And in keeping with our commitment to public transparency, we also welcome all of you who are listening in to the proceedings today, and thank you for your time and interest. And we trust that it'll be as informative for you as it will be for PCORI. And as Dr. McGinnis mentioned, and as many of you are aware, PCORI was authorized by Congress back in 2010. And we were reauthorized in 2019 and are an organization that's really governed by our healthcare stakeholders. We fund comparative clinical effectiveness research that engages patients and stakeholders and answers real world questions. And our mission's really about helping people make informed healthcare decisions and improving healthcare delivery and outcomes by producing and promoting high integrity, evidence-based information that comes from the research that's guided by patients and caregivers and the broader healthcare community. And we're excited to be envisioning our next phase for PCORI and feel that really it's only possible because of the organization's accomplishments over the past decade, its commitment to research done differently, as Dr. McGinnis mentioned, and our unique mission. And some of these accomplishments over the first decade have influenced a research culture, underscoring the value of a patient-centered and stakeholder-engaged approach to research, and also have delivered research results and platforms for implementing findings for impact, really, on patient health and healthcare. And as we look forward following our reauthorization and our 10 years of committed funding ahead, we're moving forward boldly into this next phase, emphasizing accelerating impact on care delivery and patient health outcomes by continually evolving in our major domains of engagement, innovation, and dissemination and implementation. We're in the process of setting our strategic plan for the future, which will guide us for our next few years. And a critical component in our strategic planning process is identifying national priorities for health, which will serve as foundational elements for our work and including the foundation for our research agenda for the future. So this is the second in a series of virtual meetings that we've been holding jointly with the National Academy of Medicine as part of our ongoing development of this strategic plan. And as such, it's one of the many ways in which we're gathering diverse perspectives to ensure that our work is really reflective of the priorities and the needs of patients and other stakeholders as PCORI plans for its future. So the input that we're going to gather today will be provided to our Board of Governors and our Strategic Planning Committee in order to continuously synthesize those areas on the horizon that may be important for PCORI to focus on. We had input from our very first meeting with the National Academy of Medicine that was really rich, and you're going to hear in an upcoming summary from Dr. Poe, our meeting facilitator and chair, that input focused on areas of social and environmental factors, technologies, optimizing value, and infrastructure. But given the breadth of all those topics covered, we anticipated we'd need to delve more deeply into a few key areas for discussion and follow-up. And today provides that opportunity. So building on the output from the first meeting, several key concepts emerged, including two that we're focused on today. The first centered around advancing a learning health system. Distinct from a learning healthcare system, the learning health system was meant to be intentionally broader and encompass all that it takes to achieve health, including addressing social determinants, infrastructure, and embedding engagement. And the second concept focused on optimizing patients' experiences and values and outcomes and value in health and healthcare. And this concept relates to something in PCORI's reauthorization language, which clarifies that PCORI-funded studies should capture the full range of clinical and patient-centered outcomes, including the potential burdens and economic impacts of healthcare. And this includes optimizing those patient experiences, outcomes, and value in health and healthcare. So we look forward to hearing from you. And as I mentioned, a summary of today's meeting combined with the input of the previous meeting will be provided to our Board of Governors. And as such, we're very pleased to have amongst the participants today, Dr. Christine Gertz, the chairperson of the PCORI Board of Governors. And I welcome you again and thank you for your participation. And it's with much gratitude and appreciation that I'd like to turn the meeting over to Dr. Neil Poe, our meeting chair and facilitator.
So from San Francisco, I want to add my welcome to that of Dr. McGinnis and Dr. Cook. We are delighted that some 100 of you out there could join us as stakeholders for PCORI to have a generative discussion of two topics, exploring what it will take to achieve a patient-centered learning health system, as Michaela just said, and how we can apply PCORI's unique attributes in a way that gets us closer to better health outcomes, better patient experiences, and importantly, improve value in healthcare from a patient's perspective. So by the end of this meeting, it would be great if we could envision what success looks like and start to crystallize PCORI's role in that regard. So let me walk you through our agenda today. We've had some welcomes by the three of us. I am going to provide a synopsis of our first priorities on the health horizon. So I'll do that in a very short discussion, and then we're going to turn on our fireplaces and have a fireside chat. And we have three speakers who I'll introduce shortly to help anchor us in our discussion. And then we'll have a short break and we'll have a facilitated group of discussion of those anchor questions. And at the end, then we'll summarize our group discussion and have some closing remarks so that we can adjourn by 2 p.m. Eastern time. Okay, well, I want to thank everyone for joining us. We have quite a wonderful roster of, of attendees here. I'd like to then next go to reviewing a synopsis of the first meeting that we had roughly a month ago. And we'll have some short slides to show you. So let's advance to the next slide. We came together for this purpose, goals and objectives. We were trying to do scanning of the terrain and convene stakeholders like yourselves to gather input and to have some blue sky thinking about priorities that are in the future on the health horizon. We wanted to engage a variety of folks, patients, clinicians, researchers, as well as other stakeholders from the broader community and identify priority issues that could inform PCORI's identification of national priorities for health with the goal of updating the strategic plan. And our objectives were to present essential perspectives related to current and emerging opportunities, priorities, and trends on the horizon in both the health and healthcare landscape, and then to discuss stakeholders' thoughts on these emergent topics. Next slide. So we had a 2-day meeting of approximately 40 participants, and it included presentations, a reactor panel, and a facilitated breakout group on 4 macro topics. And the macro topics are shown here: social and environmental factors, technologies, optimizing value, and infrastructure. Next slide. So the presenters underscored 6 compelling challenges that needed research guidance, and they're shown here. The first is how structural racism and its manifestation either explicitly or implicitly impacts healthcare, and research. And the second was transformation of the health research ecosystem to ensure diverse and inclusive participation in research. And importantly, the equitable application of evidence in practice. The third was fundamental misalignment of healthcare around service volume and price rather than value, health, continuity, and patient and family priorities. Fourth was the lagging use of data to accelerate learning and improvement in comparison to other sectors, and the gap from research to practice that has impeded discovery and application of new innovation. Fifth, opportunities to learn from this hopefully ending pandemic about innovative ways to redesign research and care, how we optimize virtual care and telehealth as an example, and the efficiency of decentralized trials. And then finally, 6 was co-design and engagement and returning results to patients as a means of accelerating progress toward a learning health system. So next slide. So after those presentations, we had a reactor panel that offered some corollary challenges, opportunities, and identified some additional themes. And the themes were around infrastructure, was that the current healthcare system is built on a broken chassis, necessitating wholesale systemic changes, including changes to public health infrastructure. They talked about technologies, that health inequalities may be further perpetuated if data used to make health decisions is not representative and technologies are spread inequitably. This was described by a reactor as, quote, health data poverty, end quote. And then social environmental factors came up. Getting uncomfortable and addressing power dynamics will be necessary steps in dismantling structural racism. We talked about optimizing value. Understanding value through the patient's eyes entails much more than just a service in inventory. So we need to think about accessing realities, including time demands, opportunity costs, and the cognitive burden of navigating a complex health system. And last, cross-cutting issues came up, the opportunity to rebuild a system of health and its infrastructure. And this could begin by centering the system on patients' and family strengths from a place of inclusivity. As a reactor observed, quote, our values drive value, end quote. Next slide. So after that, in our initial meeting, we had breakout groups to delve even more in depth on those topics. And some additional synergistic insights came out. One was about evidence application. We need to close the research to practice loop by ensuring dissemination and translation of evidence in a timely, sustainable, scalable, and understandable way. Our participants talked about data networks. The linkage of data, systems, and networks during this pandemic has supported the discovery process and potentially serves as a collective disruptive opportunity. How can we hold the gains from what we have learned and maintain the kind of collaboration that we have seen? They talked about organizational structure, function, and culture. Can we create a roadmap for an adaptable, technology-forward infrastructure that supports rapid learning, that describes the attributes and requirements that are essential for progress? And then collaboration. Interest in working across sectors has grown during the co-occurring crisis of COVID-19 and racial inequity, and how can this interest be sustained over the long term? And finally, intersection and integration, that healthcare's proclivity to be the consumptor of resources diminishes other vital social and infrastructure investments, and health system change strategies must account for the integration with public health and other services. So next slide. So this was just a summary of key insights, from all that I've shown you, that the priorities for health must address structural and systemic issues. Achieving health equity for all entails a deeper exploration of how racism, bias, and power affect health and healthcare across the entire continuum. And we need to reinvigorate our infrastructure to support transformation to a data-driven learning health system. The COVID-19 pandemic underscores the deficits and vulnerabilities and illuminates the essential need to transform and integrate public healthcare delivery and research in a way that's patient-centered, technology-forward, and leverages data. And we need to create a system of health, as Dr. Cook led us off with, rather than a healthcare system. We need to shift from a fragmented system focus on surface and volume and orient a new integrated system around patient strength and patient values. Next slide. So meeting one urged bold change. One of our participants said, doing a different thing, we need to do a different thing, not simply doing the same thing differently. So this meeting provides an opportunity for us all to explore the output and discuss in depth regards to these two questions. What will it take to create a patient-centered learning health system with respect to infrastructure, technology, and engagement? And how can PCORI use its research strategies, its unique role and activities to grow patient experience, outcomes, and value in health and healthcare? As with our first meeting, today's dialogue will be underpinned by the integral importance of centering PCORI's efforts in health equity. So that, thank you for listening to that. We wanted to give you a sense of what happened in that first meeting that we had, so that we can build on that, some of the themes today, but explore others as well. So next up, we are going to turn on our fireplaces and have a little fireside chat. We concluded that it was important to take a closer look and have a deeper discussion about some of these topics. And those topics are namely a learning health system that's truly patient-centered. And to this end, we have 3 exceptional panelists joining us this morning to start off our fireside chat. You have their bios in your briefing book, so I'm going to keep the introductions brief so we can get into the conversation. So first off, we will have Dr. Sachin Jain, who is President and CEO of the SCAN Group and Health Plan. Then we will have Dr. Consuelo Wilkins, who is Vice President for Health Equity at Vanderbilt University Medical Center and a professor of medicine at Vanderbilt. And finally, Dr. Atul Butte, who is the Priscilla Chan and Mark Zuckerberg Distinguished Professor and the inaugural director of the Bach-Art Computational Health Sciences Institute at the University of California, San Francisco, where he's also the chief data scientist for the entire University of California health system. So let me open with a question for us to think about. What we want to be is future oriented. We want to think, let's say 5 years out. And we want to ask the question, how can we realize a patient-centered learning health system underpinned by health equity? And so I'm going to have Dr. Jain lead us off. Perhaps he'll tell us about delivery system innovations, health IT, and driving value in coverage. So, Dr. Jain.
Thanks so much, Dr. Poe. Real honor to be with you all. I would say, I think the challenge we have is in actually making this agenda real. And I would say one of the most significant opportunities we have to actually make the agenda real is to tie it more strongly to payment. And I think one of the best opportunities to do that potentially is through the Medicare Advantage program. Almost kind of unbeknownst to, I think, many of us, Medicare Advantage has grown, pretty significantly in its popularity, particularly among, minority and low-income populations. And over 40% of Americans now get their Medicare through the Medicare Advantage program. And there is a significant pay-for-performance component that is embedded within the Medicare Advantage program, namely star ratings. And the payment is very closely tied to your star ratings. I think we have a missed opportunity to actually tie star ratings to performance around health equity and disparities. I think there's an opportunity to embed, measures of performance that are tied to clinical performance in particular populations and subgroups, and include, potentially payment adjusters that are tied very closely to health outcomes achieved for distinct populations. So I think, the most important thing we can do to accelerate this agenda is to really tie payment much more closely. And I think Medicare Advantage ends up being one of the most significant opportunities to do that.
Thank you, Dr. Jain. So let's have next up Dr. Consuelo Wilkins. Dr. Wilkins.
Thanks so much. Well, first I'll say I'm not sure that any of us need fire. I'm jealous of the sun I see in Atul's background there. But I think that if we're really going to focus on person-centeredness, and I think we should be intentional in thinking about people and not just patients. The etymology of the word patient is someone who suffers. And I think that puts individuals who have health conditions at a disadvantage. If we really want them to be centered, then we need to be able to actually elevate their viewpoints and bring them into these positions where they're not, there's not this power dynamic that they can't actually express their needs and be involved in setting agendas and helping design a health system and therefore a learning health system that really is truly centered on people, their needs, their beliefs, their attitudes, and the myriad varieties of those that we will experience, that we all experience as being part of a health system. I think for the health equity piece, we really have to carefully consider if we're talking about health equity or health care equity. Because we're talking about health equity, then we need to prioritize these upstream factors, social determinants of health, transportation, housing, educational opportunities, economic opportunities, living wages, all of those things we need to think about, as well as structural racism and how we actually will try to dismantle these policies and practices that are long-standing. So I think we have to take a step back and really make sure that we're all on the same page about what we mean and who should be at the table when we are making these decisions.
Thank you, Dr. Wilkes. So, Dr. Toole-Butte.
Great. Thanks for having me. And sorry, I'm outside. I had to drop my daughter off at school, amazingly, today. So when I hear patient-centered learning health system, I think of a phrase we use at UCSF called precision public health, right? The way we treat a patient with diabetes that lives, let's say, in a wealthy neighborhood is going to be very different than a patient living in a challenging neighborhood, even with the same worsening hemoglobin A1C. So obviously capturing social determinants of health is important, but we're also increasingly saying that if we capture a few numbers, that's good enough, right? Distance to a grocery store at University of California for all 7 million patients. We have our area deprivation index, social vulnerability index, healthy places index, and more indices. I'm increasingly worried though, why are we capturing all of these social determinants of health? Are we doing this to help try to control these elements of important care for our patients, or control for these elements? In other words, to be able to bill more in or bill differently when we see these patients. So I think we're going to go through the mechanics of capturing more and more of these elements. I'm a little worried about the intent of why we do it. So I think, so at UC, we're obviously capturing more data from patients, right? Those that have the right devices, blood pressure cuffs at home that talk to the smartphone, that talk to us and our health system. And those are hard to get working, right? As we all know. But the reverse is still missing. We're all now exporting data to patients, again, the ones that can figure out smartphones and have these kinds of health, digital plans. But where are the apps that actually show patients what to do? Patient-oriented decision support. I think writing papers is fine, okay? That's a great productive use of academic time. But how does that actually help a patient in the end when the doc isn't even reading the papers, right? So I think direct to patients is the future. That's engagement. I think there's more ways to engage with patients than just writing papers to influence the doctors. I see a world where we're going to use all these digital tools and AI, machine learning, all the rest, to directly give support, decision support to patients now that they're getting as close to their entire medical records as we can imagine, I think.
Okay, thank you. So let me just ask a few questions, try to stimulate this our group of panelists. Dr. James, someone had said in the chat that should we tie all these metrics to payment? Is that the path to the future, rather than having metrics that are not always tied to payment? Is that?
Yeah, I know. I think the chat was a little bit more critical of the perspective than even you're kind of saying out loud. But I'm happy to take the question as it was posed. I just don't know how to make this agenda real without actually raising it to the level of an organizational P&L. I was separately texting with a member of this meeting, asking them, what are our real achievements and accomplishments in this field over the last 10 or 15 years. And I think we've done a lot of phenomenal research, but when it comes to translating that research to Atul's point into kind of prime time real feet on the street change for patients, the things that seem to move real behavior, when you look at it at an aggregate level, is transforming how we pay for care. I'll tell you something that we're doing at SCAN that is somewhat relevant, which is we looked at the sub-measures of our star ratings, and we looked at our medication adherence data and realized that we had substantially higher medication adherence performance in white members than we did in African American and Latino members. And what we've decided to do is tie our bonuses to whether we could actually close this gap. And you can bet that the organization is aligned around actually closing that gap, because we're literally putting our own money where our mouths are. So I think that incentives are important. What you measure is important. Transparency is really important. And I think at an organizational level, we have we talk about generating new data. I think that's a major theme here. But there's also a lot of data that we already have about our poor performance that we're just not talking about. And so I think we have to kind of find organizational levers to make these agendas real and get them out of the science lab and get them more into kind of, real practice at the organizational level.
I would caution against, tying too many things though to payments, because, who's the payment? To whom is the payment? If we're really centering people, patients, families, then we're deciding that those who get paid for delivering care or some services then are the ones who are really making the decisions. So if we're going to tie to some incentives, where are the incentives for patients, families, communities to try and solve some of these more complex challenges, especially as we talk about health equity? And if we're talking about payers, perhaps we're talking about state and federal payers for Medicaid and Medicare, but who is the payer for people who are uninsured? And for states like mine in Tennessee, where we've not expanded Medicaid, there's a large number of people who do not have a payer other than themselves. So again, where is the incentive? How does that align? And if we're going to talk about payments, then how do we bring in social services, social sectors, really, again, who are focused on these critical social determinants like housing, transportation, economic opportunities? Are they going to get some of these payments directly, or are we going to continue to tie these payments to health systems?
So I hear the question is, how can payers engage patients better, and so that patients can be involved in more involved in how resources and performance is measured. Any thoughts about that?
Well, I would love to see patients and families be more involved in really determining what those metrics and measures are. We have lots of, and thanks to PCORI for really elevating this, we have lots of different models for engaging patients and families in meaningful ways. But a lot of that depends on having the infrastructure to do that, and people who are responsible for it, and some system of accountability. How are patients and families supported in bringing their viewpoints to the table? What resources will allow them to meaningfully engage? And how will we be responsive to that feedback in some way that we're also co-learning, that they're not just giving us information, that they are teaching us something, and we have the humility to actually accept that information and use it.
Yeah, Dr. B, you kind of touched on this on the decision aids that people putting those out, and what are they really doing? Are they really helping people, or is this just an academic exercise?
Yeah. So first to address the previous question, I'm also a believer that the dollar is going to motivate a lot. It's an expensive healthcare system, and what's even more depressing to me is there is actually, in my view now, there is no waste in the U.S. healthcare system. And the reason I say that is because you can point to any person, and we in health system are great at pointing at the drug manufacturers, they're great at pointing at the hospitals, we're both great at pointing at devices and payers and PBMs. but everyone in the system feels like they're earning their dollar right now, right? Everyone goes home feeling like they worked hard to earn their dollar. And so it's really hard to easily point at waste, but the dollars will motivate things here. So what I would say, again, a lot of this is in the context of giving advice to PCORI here, right, as an institution. I think what I would recommend in that context is to find operational reasons to stay relevant here, to be relevant to payers, to be relevant to companies with self-funded health plans, and to be relevant to patients directly. Now, the digital tools to help them are just going to get the topmost strata of patients here, right, in terms of socioeconomic status. No doubt about it. But I think it's still reaching patients backwards in a way, of, in the effector arm of a learning healthcare system, instead of depending on doctors or health systems to do that. But to really directly answer that first question, I absolutely believe the dollar is going to motivate things. We've had projects at UC where we've used system-wide data where we've noticed drugs that we're using that are absolutely not needed, okay? The best example is IV Tylenol, especially when a patient's already getting other oral drugs. You know, we make a master list of every single patient in the University of California getting IV Tylenol. It doesn't need to be IV. It's 400 times the cost for that dose. And we literally make a list of every single doctor doing this, and we start to make phone calls, and it's plummeted across the health system now, right? And sometimes it takes that relevance to just actually make the change instead of just writing more papers about it.
So if the dollar motivates people, is the dollar in the right hands to, you know, to achieve what, let's say, Dr. Wilkins called accountability? Anybody want to comment on that?
Well, I mean, I'm definitely for linking incentive pay at the executive level to outcomes. I mean, I think that's one of the most powerful things that we can do if we set a real vision and some goals and tie that to executive pay. Then I think we'll start to see some of the structures and policies put in place that would really propel this forward. But that's typically a decision made at the organizational or the institutional level, not something that we can dictate as an external policy.
So to get there, what do we need to learn? What things does PCORI need to think about in terms of generating evidence and new knowledge to get to some of the ideals that each of you have talked about?
I would chime in and say, I think there needs to be kind of creative relationship building across federal programs. I think, there's a ton of opportunities to partner with CMS in particular around, developing CMS as a potential effector arm for the insights that are developed by PCORI. I think, that kind of linkage could potentially be, very powerful in terms of driving, knowledge into practice. I think that's our gap. I think we have, a lot of knowledge about, what moves, patients and what moves families. I'm not sure that we have effector arms that actually, drive that knowledge into practice. And so I think, building some of that plumbing will be highly relevant over the next decade.
So connection, some said that if we connected, CMS and, environmental health and housing,
I guess what I'm a little bit struggling with is kind of a theory of change. I'm watching the comments here and in the chat box. I don't know what our, kind of collective theory of change is in this field around, there's new knowledge development. New knowledge development leads to papers. Papers lead to, dissemination. Dissemination leads to maybe some, micro changes in practice. If not payment, then I'm just kind of curious how we can evolve the field so that some of these insights are actually being driven into practice. I'm just, it's a question for the group, really.
Others?
Well, I do think that gets to the definition, back to the definition of person-centered learning health system or patient-centered. You know, are we talking about health outcomes at the individual level? Is that our idea of patient-centered? Are we talking about patient satisfaction? Or are we really talking about centered in the beliefs, concerns, priorities, needs of people and their communities? And if we're talking about that, that's a very different working structure, the resources needed to support communities, community organizations, again, the social services sector, that's a very different infrastructure. And so I think we have to be true to how PCORI has defined person or patient-centeredness and these beliefs and attitudes, and not how we traditionally in the health system have defined patient-centered as just individual patient level outcomes, and not really focus that we as healthcare providers and those in the health system have decided are metrics and outcomes. They are not centered in the beliefs and the needs of those individuals.
I would just want to caution that I don't see us. There is no one broad brush that's going to solve the whole system and the whole problem, and even what PCORI should do next year, right? There are different levels of questions, right? The same health system here in California has to figure out, why is this patient living in an area deprivation index of 9 having a worsening hemoglobin A1C? At the same time, we're trying to figure out, did the 150 patients we treated with CAR T cells actually get something from $1.5 million worth of care, right? So we have both extremes constantly. One broad brush isn't necessarily going to, it's going to be hard to summarize what we all need to do next with just one broad brush.
That's what we're here to do, to try to figure that out. And provide some guidance on, on what's needed, what kind of infrastructure, is needed to move us, to move the needle in, let's say, 5 years. So we can't give up.
Neil, if I would just say, one thing about the infrastructure for a person-centered learning health system, we at Vanderbilt and also in partnership with Meharry have, more than a dozen years of effort focused on community engagement and building the infrastructure where we're intersecting with, more than 200 community organizations on a regular basis. And we have community members, patients who have been serving in leadership roles who are embedded into our teams. And because of that, when we launched our learning health system a few years ago, we included community members as part of that team, attending the team meetings, helping to prioritize decisions, deciding when we needed to have community engagement studios. And so we want to make sure we don't overlook that need to have the infrastructure built and supported to do that kind of engagement long term.
Great comment.
I'm a little cautious with this word infrastructure, especially with the lead in that you had, Neil. In my view, in my opinion, purely opinion, it is not technical reasons why we don't bulk data share, for example, medical records or the rest with each other. It's not HIPAA, it's competition. And whether we like it or not, we have a competitive healthcare system, just like we have a competitive justice system, right? I have numerous examples where health systems directly or inadvertently use data against each other, right? And even during COVID, not sharing their ICU counts and things like that because they didn't want to lose money on patients. So the reasons to share data, the core of this infrastructure, have got to be beyond grants and papers for academics. Grants and papers, grants and grant revenue are in millions. Healthcare system revenue is in billions. And I think it's got to stay, my recommendation is to be more relevant to the top line dollar, to create that kind of value for health systems. We all know that a value-based care system is coming, and we say it keeps coming, but it is in many ways already here.
Yeah.
Inpatient admissions and things like that. If we waste money, we're going to lose money, and there's directly things I think the system can do to help. So go ahead, Sachin.
No, I was going to say, I think the future is here. It's just unevenly distributed, right? And I think our job is to, there was this question about kind of where should the dollars sit. And I think as much of the dollars as possible should be delegated to the provider organizations, so that they can actually, manage the risk and start to build, the micro level they'll have the margin and the capital to build the micro level interventions that are going to make movements on the types of things that we're talking about here. The other thing I'll just say is, and I increasingly view this as the root cause of almost every problem we're trying to grapple with, is we need to develop a higher calling to leadership in our industry. I think that, we don't have a lot of leaders who are carrying this agenda and are driving the cultural changes that need to exist at the organizational level to actually make these things matter and make them real. I think we are confusing kind of, in being a good administrator with being a good leader. And I think we need more leadership, more definitive, declarative leadership on these issues, coming from, department chairs, organizational C-suites, because, in the absence of those messages, organizations won't move to prioritize, these themes.
Yeah. I want to get back this thing about, that Dr. Butte brought up about the competitive healthcare market. How do we get in a competitive healthcare market accountability at the community level that Dr. Wilkins talked about? Are there kind of models we should be looking at and trying to study that actually PCORI could study to see how they would work? Any thoughts about that? Everybody's stunned.
You're drawing a blank. You're trying to solve the entire U.S. healthcare system here in one question, right?
I think it gets to the crux of, are we really going at the things that patients and their families want in communities, while everybody else is just competing against each other for that dollar? And what we want is accountability for, health and patient outcomes that matter to patients.
Why is it that those two have to be in opposition with each other, right? I mean, so one could argue a future ideal state would have accountability to those communities, to all communities, as the incentivized issue, right? As the incentivized metric, which is why I started my leading comment with exactly this. We're all getting better at measuring social determinants of health, but I'm not really sure if we're using those to actually fix a problem rather than just control for it to be paid better, right? I think, but there's a comment in the chat, which is exactly what I would resonates exactly with how I view. Why not compete on accountability? Exactly.
I think I would say also, what are the incentives for health systems or healthcare delivery systems to partner with community organizations and public health systems to solve these problems? Because I do agree with Atul that, there seems we still function in these isolated ways, and many times seemingly competing and developing different structures and infrastructures and supports for work that in parallel, sometimes overlapping, but not collaborating with each other. I would also say that, we're capturing some social determinants of health better. I agree with that. But are we capturing, again, in the person-centered, family-centered, community-centered viewpoint, are we capturing those social determinants that these individuals want or think are most important? Should we be looking at food deserts or food swamps? Should we be looking at police response times in communities? Should we be looking at, other factors than high school graduation? Should we be looking at quality of schools? There are lots of other things that are important that we're not actually capturing, that for certain health conditions, as was described before, diabetes, that might be much more meaningful. Do you have safe places to walk in your neighborhood? Again, what are the other resources needed for people to be healthy?
I do think we have to position ourselves as advocates on these issues. But I will say, I've watched the healthcare industry kind of creep more and more, outside of its, kind of core knitting, to now, be now taking ownership for housing, taking ownership for transportation, taking ownership for things that we're not good at. We're not good at a lot of, our own basics. I wouldn't necessarily trust us to administrate a lot of what is under our current charge, and now we're kind of expanding our charge. And so I think this notion of partnership that Dr. Wilkins raises is important, and I think it's important for us to really define our scope very clearly and not fall into the trap, I think that Atul referenced, which is kind of using the dialogue on social determinants of health to raise our own kind of reimbursement, as opposed to necessarily using it to advocate for the right things to happen to patients and families.
And I was just going to add, I think advocacy is important, no doubt about it. But I also raise caution when I hear leadership, really worried how a hospital system, which is still struggling to even be cash flow positive, let's say, in taking care of patients, is supposed to not take on housing and opening grocery stores and things like that. I mean, I think advocacy is certainly there. Going beyond that is still seems like a challenge to me, and how to get hospital leadership to even feel like there's a competency there to do some good.
I mean, I agree. We in health systems shouldn't be taking it on, and we shouldn't be leading it, but we should be partnering, and we should be supporting, and we should be thinking about shared metrics and outcomes that we could be collecting that are relevant and can inform our other decision making. So I think sounds like we're all agreeing.
But I will say I've seen an increasing use of social determinants of health to excuse poor clinical performance at the organizational level. I was in a forum with a CEO from a New York-based hospital, and he said, "Oh, the reason we're not doing better on these metrics is the social determinants of health." And while I think that there is some sympathy for that perspective, there's also just like doing a better job at your job. And I think increasingly social determinants of health are being used as a form of risk adjustment, as opposed to a form of motivating kind of better action or better behavior or better performance. And I'll also say that there's not a ton of evidence base that health system led interventions around social determinants of health actually make a difference. And so when you look at that, the lack of that evidence base and the increasing use of the terminology, which I think oftentimes is used to obscure more specific language like racism and poverty, which is the real issue we're trying to confront. I think we may be obscuring the bigger issues here that we need to be taking on.
Yeah, I 100% agree. We cannot allow ourselves to excuse poorer performance in more marginalized and disadvantaged communities, as it's because of these underlying social determinants of health. And certainly agree that's where we need evidence. And I know that's of interest to PCORI. Where is the evidence? What kind of evidence can we generate? But I would also reject that we don't have evidence that can help guide us. I mean, community health centers, federally qualified health centers have been serving these populations for a long time. They've not been necessarily in the space of traditional evidence generation. They're less likely to be applying for some of the grants and awards. But these are stakeholders that we absolutely must bring to to the table. You know, for a federally qualified health center, their boards of directors have to have a minimum number of people from the population they serve. They have done this work for many, many decades. And there are lots of things that we can learn from them if we let go of our ivory tower, viewpoints about, who can generate evidence and who is an expert in a certain space.
So building on that, are there any data and technology needs that might help improve the situation? In terms of generating evidence, are the data systems the right things in the right places?
I started to address a little bit of this. I mean, I think one big component of I think what PCORI has been doing, and Priority of the Future is still electronic health record data. We're capturing more of it. We're getting to more of it. We're releasing enormous amounts of it now to patients as of a couple of years ago and a couple of weeks ago. I don't think patients really have enough tools to actually even process or use it. And I think I can see us getting to several national networks where more data is shared with each other in non-competitive ways. But I don't see one national network happening anytime soon with data. Again, that's one component of a digital infrastructure here for PCORI, only because we're in a competitive healthcare system. It's much easier for me in San Francisco to share data with UC San Diego than it is for me to share data with Stanford, our neighbor here, only because we put up billboards next to each other to get patients, right? And that's a fact, that's the reality, right? Both of our health systems make billions of dollars. So I think, maybe, the phrase we keep using all the time is Star Alliance, right? We'll have a Star Alliance of partners that want to work with each other, but we don't just have one Star Alliance, right? We have Sky Team, we have the other one that American has, One World, right? So we still have competition there, but we have national networks as well. So I could see that happening in the United States.
EHR data are typically not what I would view as patient or person-centered. We rarely get information about the beliefs, the attitudes, the priorities, the needs of individuals. I shouldn't say rarely, I'll say infrequently. Some of us are doing it better than others. It's probably down to the individual practitioner more than individual systems. But even as we document those needs and priorities, it's typically interpreted by the provider. So, an individual comes and they tell me what they want their outcomes to be, what their priorities are, and I, as a physician, am documenting it. And so that relies on our ability to understand from a cultural standpoint, a level of humility, to ask the right questions, that they view us as trustworthy enough to share that information. So I think, again, bringing in that health equity lens, we always have to think about what are the unintended consequences of using a specific approach that was developed for a majority population. What are those consequences, negative consequences for people who've been marginalized?
Okay. Well, I have to say thank you, all of the three of you, for a very interesting discussion to lead us off with some of the important issues to become a learning healthcare system. We're going to take now a 10-minute break, give you a chance to stretch, get some refreshments, and come back. And we're going to come back and continue this discussion as a group. And so think about, I want our participants to think about what they heard and be ready to share your own thoughts about what we need to do and how PCORI could help in this journey. So we will see you back in 10 minutes at 25 after the hour. Thank you. Okay, welcome back, everyone. It's 25 after the hour. Hope you had a good break. Next up, we are going to go on to our group discussion. And this is a discussion about what it will take to reach the aspiration of a learning health system that is predicated on the use of representative clinical data and research evidence for better outcomes and more effective and efficient and equitable care. And how can PCORI's mission and mandate to conduct patient-centered comparative effectiveness research, how can it reach that mandate? So we have about an hour to discuss those questions as a full group. Those are in your briefing book, those questions, and there's a few correlate questions to stimulate your thinking. So we're going to take about 30 minutes on each of the questions. But first up, we have 2 to 3 people who have lined up already to try to get us started. And I'm going to invite them and just have them again introduce themselves, who they are and where they're from, and then have them make a few reactions. So they're Dora Hughes, Anand Parekh, and Frank Opelka. So Dora, why don't you get us started?
Thank you, Dr. Poe, and thank you for inviting me to serve as a reactor today. I will start off by saying, because I am, again, on faculty in the Department of Health Policy and Management at an academic institution, some of the comments about the value of these papers that we keep writing were making me cringe through the fireside chat. But that being said, this was a very rich discussion, and I think there are so many key points that we could focus more on. One that I wanted to focus on that came up through all of the comments by our prior panelists was really this notion of accountability to communities. Atula mentioned that we as healthcare providers are doing a much better job at documenting the social needs of our patients and describing the social terms of health, but can we move beyond that? How can we move beyond that to doing a better job to actually addressing these issues? And I think that Dr. Wilkins added on the very important points too, is, and how are we working with communities to doing this? Are we prioritizing the needs of our patients as they would prioritize them and not as how we would prioritize them as providers? And then I think that Dr. Jane had a very practical point too, that to the extent we're doing more of this, what are the financial mechanisms? What are the financial incentives that would both allow and encourage providers to do more in this space? And also, very importantly, that we also have to avoid health system creep. I mean, there are others who are actually much more skilled and knowledgeable and have the capacity to do this, to address the social needs of our patients at a high quality level. And I think I also was struck by the practical questions, like how can PCORI be the effector arm, or how can it partner more and serve as a resource? And so in terms of this accountability to communities, this is a very real issue. There are a number of accountable communities for health models that are currently underway. And we don't have to look even beyond CMMI, the Innovation Center at CMS, to see some of these models and learn from these experiences. We know one such model, the Accountable Health Communities, is in its fourth year of implementation, and it will wrap up next year. What we learned through the AHCs is that it is actually hard for providers to screen their patients for social needs. It has been hard to actually link patients to social service providers who can help address these social needs. Similarly, CMMI has launched Integrating Cares for Kids, the INC model that again is seeking to partner providers, public health, social service organizations together to address the needs for the pediatric population. Just last year, they launched CHART, Community Health Access and Rural Transformation, which again is focusing on accountable communities in rural areas with the same intent. How do we work across sector to better address the health, not just the healthcare needs of our patients? And even beyond these federal models, we certainly have a number of models that have been launched by foundations, whether that's the California Accountable Community Health Initiative, CACHI, or the Episcopal Health Foundation just launched TACHI, the Texas Accountable Communities for Health Initiative. And these are building on a number of state efforts, whether that's Rhode Island's Health Equity Zones or Oregon's Coordinated Care Organizations. I mean, there's a lot of different initiatives that have been launched fairly recently in this space in the 3 to 5 year period that are really looking to understand how we as the healthcare system can work with public health and especially the social services sector to address the health of our patients. And so then the question then I would lay out for all of you is from the standpoint of evidence generation, what are the opportunities for encouraging cross-sector collaboration to drive patient-centered, high-value healthcare? What can be PCORI's role in better helping to generate this evidence at a theoretical, certainly, but also at a very practical level to drive greater movement in this area? So I'll stop there and I'll turn the virtual mic over to Dr. Parekh.
Okay, Dr. Parekh. Thank you, Dr. Hughes.
Thank you, Dr. Poe. Thank you, Dr. Hughes. I agree. My reactions are very similar to Dora's. I thought we've had a tremendous discussion. I think we all also feel that this group in PCORI, we're not going to be able to solve all of healthcare's challenges, but the key questions are: what does success look like for PCORI in the second decade? How do we catalyze informed decisions? What's the health equity research agenda? I agree with Dora. I thought the panel was really right on. I think Sachin's points about quality metrics being the currency of value-based healthcare transformation, focusing on all the levers that drive impact, payment, incentives, and there are many others, so I don't think we should just limit it to that. But at the end of the day, this has to be about impact, and I think the second decade for PCORI, PCORI is going to be positioned to really hone in on dissemination and translation. I think that's so important. I think Consuela's points about, if we all agree, and I think most of us do, that 80 to 90% of health outcomes are determined by what happens outside the four walls of the clinical care setting. If we agree on that, I think it's a valid question: is PCORI ready to take on the challenge, the data, research, infrastructure challenges of really honing in on many of those factors that are impacting health and preventable healthcare costs outside the clinical setting? And I think that is a critical question that I think we all need guidance on. And then Alto's point about digital health being transformative over the next couple of years and direct to patients and patient-oriented decision support. Again, the open question for PCORI, is PCORI positioned to leverage and take that on? I think are very open questions. I think it was interesting that what I haven't heard in the entire discussion so far is COVID. And I think we also appreciate the fact that COVID just doesn't go away in 3 to 4 months when we reach herd immunity. This will be a transformational event in this next 10 years for PCORI as well. So many issues here in terms of research agenda, from disruptions in prevention, disruptions in chronic care management, the research and policy agenda around telehealth and equity, long COVID syndrome and the millions of Americans who will experience that. And so understanding how COVID fits into this sort of second decade research agenda are pretty important as well. So I agree with a lot of the sentiments already expressed. Again, I think that the caution for this group is, again, there are many challenges in healthcare. I think the specific question probably most important to PCORI is, where does PCORI fit in all of this? Certainly needs to drive where it has during the first decade in terms of focusing on high priority areas, focusing on dissemination and translation. But I think it's important to really hone in on where PCORI can focus. So with that, I will pass it along to Frank.
Thanks, Dr. Brick. Dr. Opelka.
Thank you, and thank you, Dr. Poe, and to the entire panel. It's been a fascinating discussion. I'm going to take a little bit different, maybe perhaps more granular look as a medical director for the American College of Surgeons. We have our own different perspective. It's not as much based on the population health issues. It's based on what's happening down at the specialty medicine point of care. And one of the constraints I think I heard the panel and much of the discussion struggling with is that our current business model is how everybody's wired. It's how everyone operates. And so we only tweak around the edges of that business model. And when you do that, there's only so much you can do. That when you study what's happening to patients, and we see this in the surgical patient all the time, patients are on a journey and they end up with 15, 20, 25, sometimes even as many as 50 different physician providers in their care journey, and nothing is coordinated. And everybody is gathering around, trying to find knowledge, trying to coordinate care, but nothing's working and it's all failing. And yet we've had this huge investment in digital health, and we've not created the kind of shared knowledge in digital health services that is completely built around the patient. It's built around each one of those tax IDs when they're faced with the patient with the best intentions. But we think there's a real opportunity for us to think about not just our individual transaction, but that patient's entire shared knowledge and how that shared knowledge is available for primary care at any point in time, directed with the patient to help guide them through an incredible maze and journey once they get into either chronic care or in acute surgical care situations. There's preoperative optimization of patients, which requires coordination. There's in-hospital coordination and shared knowledge. And then there's post-hospital shared knowledge that everyone should have access to in a common architecture, open standards available for everybody to generate shared knowledge. And there are ways to then tie a new business model onto this. We've got to get more creative than say, we're going to live on the same chassis of fee for service and try to leverage all these advances that are in front of us. We've got to come up with a new chassis, and it has to be different. We have to have shared accountability for what those patients expect us to deliver to them as a team. But our business model fractures us. We all move away. Hospitals are not even measured by the same metrics that surgeons are, or anesthesia, or the pathologist, or the radiologist, or the primary care. So how are we all gathering around the patient if we're all pointing out in different business models to achieve payment? I think we've really constrained ourselves with our business model. Our care models, I trust. I love when all the team comes together around a patient and they succeed. How do we build that together in shared knowledge? What's the infrastructure needed? I don't think it's the EHR. I look more to the HIEs for building common data models with shared knowledge that's available to optimize care. And again, thank you very much for a very, very well-run panel, Neil, and I tip my hat to you for your work.
I want to thank the three of you for starting off this discussion, and but we're going to let others join in. You're free to come back and offer your thoughts in the conversation if you have additional thoughts. So what I'm going to ask is people use the raise hand function on Zoom that's usually in the reactions panel. And if you'd like to add something to this conversation. And to our audience, remember you can use the chat function as well. First off, we have Gwen Darian to offer some comments.
Hi, thank you. Can you hear me? Okay. So I actually think that I'm not sure if we ever answered the question that Dr. Wilkins posed, which is, are we talking about health equity or healthcare equity? Because I think that is really the central place to start to think about what we are considering as we look at PCORI going forward. And one of the questions that you had to the panel was about how can patient-centered value be achieved in a manner that upholds and centers health equity? And I think that in order to do that, we have to actually answer that question. And I also think that one of the other things that Dr. Wilkins talked about and everybody responded to was this idea of, are we looking at individual patient outcomes or are we looking at patient and community outcomes? And if you take that from the point of view of a patient or a point of view of patient advocates, which is the group that I represent in this conversation, it's really very much on a continuum. There are individual goals and family goals, and there also are community goals. But I wanted to get back to I really wanted to get back to that original question of Dr. Wilkins when she opened her response, when she opened her fireside chat. So thank you.
Thank you. Let's see, next up, let's have Dr. Siegel.
Hi, thank you, Neil, and thanks to all the panelists and reactors. I wanted to make a comment. I was struck by the, I guess, the prevalence and around use of markets and competition as the vehicle for achieving superior outcomes. And I want to caution us about that, especially if, for instance, if we look at incentive plans, for instance. We don't know that those things necessarily work or what makes them work, under what conditions they could work, including incentives for executives. More broadly, we know that markets fail, and we know that market failure is a reality. And I work for lots of hospitals who experience that on a day-to-day basis. And that's when government is asked, or we push government to intervene in some fashion. So I would be cautious about the market-based language and exclusive market-based approaches or exclusivity of such that we seem to be heading towards. And we'll also be cognizant of the fact that there are other levers to change behavior, whether that's, for instance, accreditation, whether that's education and how we design curricula, and even, and I hate to say this, even regulation as another lever. So I hope that as PCORI thinks about interventions, that it thinks more broadly than ones that are purely or primarily financial and market-based.
Well, thank you. Very, very, I think, important points, because that is the system that we also have now, where we do have these other levers that can be exerted in our environment. And really study how the influence of those and how we might learn from that. So let's have, I think it's Dr. Blake, Kathleen Blake?
Sure, thank you. So amazing conversation so far, and I really appreciate the pointing out and the restatement of the need for clarity about whether we are talking about healthcare or health. And I think that if we were in a large group that is not just comprised of people for whom health care is what we focus on all the time, I think that a very large group of people in this country would say, hey, just get to health, not the health care. So I'm supportive of trying to really understand that distinction. But secondly, a lot of what we've talked about so far seems to focus on large organizations, large or big levers with respect to issues such as competition, consolidation, whereas I'd really like to see PCORI look at the importance of relationships and relationships from one organization to another tend to be transactional. Relationships amongst people who know each other, perhaps within a community, who trust each other, who have witnessed each other's behavior over time. Those trusting relationships, I think, have perhaps been undervalued as we've seen organizations get bigger and bigger and bigger. Thank you.
Thank you. Thank you. Do we have other comments that folks want to make? So let's have Jeffrey Schiff. Is that Dr. Schiff?
Thanks for this great conversation. I just wanted to emphasize or put a strong point on the fact that I think we need to really think hard about how to move money to communities. I think someone earlier talked about not overreaching the health system creep, but I also think that we don't need a whole lot of money in communities to help move the needle, and I think that would make a difference. I come from the Medicaid perspective, and I just think that in Medicaid there's a lot of concern about how to both look at equity, but also how to look at the performance of the system, and where and how money should be allotted into community organizations. And I think that that's an area that's fertile for research. I get really concerned about the emphasis on large payers and large systems and the value add that they make, and how hard it is for primary care and providers and for communities to get funding they need to make a difference. And then the last thing I'll just say is that in trying to get to a learning health system, I think we really need to think about what measures we feed back to providers, and how timely we can make that, and put some emphasis on getting measures that mean something to providers back to them. Thank you.
Well, thank you for bringing, and also for bringing up Medicaid, because we have 50 different experiments that we could have in the US. Let's go to Janelle Krishnamurthy.
Hello, thank you very much. I thought I would maybe address your first point here, because I think in light of, as another participant remarked, of COVID, we have found how fragile our public health infrastructure is, how fragile our local public health departments. And I think there has been a real education and eye-opening from so many different critical stakeholders that aren't our usual healthcare stakeholders. I mean, your movie theaters, the cruise industry, the sporting events, the, what would I say, the concerts and entertainment are like, who are these people that are giving us guidances to wear masks, close our facilities, etc.? And I think we really did find out, unfortunately, how fragile that infrastructure is, that so many systems in our communities depend on. So I do think that is a really important question that would be important for PCORI to look at as we're talking about communities and health systems within your local public health departments, because unfortunately, we all have short-term memories and people will forget, and the funding will not be there for these local health departments. Then we'll be in the same place. So I think that is really important to examine.
Thank you for raising that point. I mean, in some sense, COVID pointed out the fragileness of those systems, but in other ways, it showed that some of those systems can work together actually efficiently. And might there be some lessons for how we connect those different sectors of our economy to produce health? So that's a very important question. Thank you for bringing that up. Okay, let's have Enrique Martinez, but I'll bring that. Have you?
Great. Thanks, Dr. Powell. So let me build on a couple of things that I heard some other folks mention, and Dr. Schiff mentioned Medicaid. I represent Association of Medicaid Safety Net Health Plans, so not the big commercial carriers, a lot of the nonprofits, ones that were created by FQHCs, those sorts of things. I mean, we have some big ones too, but a lot of government-run ones out in California. I work a lot with them on their quality and operations work, their issues related to social determinants of health. So I think the issue that was brought up about health, are we looking at health versus healthcare, health improvement, healthcare improvement? It's a critical issue. Our plans are very mission driven. They try to go beyond healthcare and start addressing the social needs of their members. They are very sort of boxed in by these Medicaid regulations, what Medicaid will pay for. They pay for addressing social determinants of health out of their reserves or out of their foundations that they might have set up. It's hit or miss. It's not sustainable. So that's a real challenge. But along with that, I mean, just sort of the overall challenge of it is really data issues. So that's a place where I think PCORI could really hone in on not only sort of the internal data issues that our plans have, and I mentioned in the chat earlier this morning that the race and ethnicity data, data about gender identity, about disability. There's all kinds of data that's actually very incomplete. So that would be a place where any support to improve that would be better. Would be helpful. And then when you start talking about social determinants of health, those are whole other sectors, whole other data sources that are not crosswalking into the healthcare system at all. Workforce issues are another place that PCORI could really do some focus on there. Sort of what's that intersection between the healthcare system and the social service system? Community health workers, peer specialists. They've done portfolio. PCORI has a great portfolio on that now. Even more would be better. And I will mention one other thing about the work that all health plans are doing now on interoperability, and really trying to standardize the data onto a single structure. That could be a huge opening for really a lot of quality improvement, having standardized metrics, even standardizing some of the social determinants of health, if we could eventually get to that. But I agree with Dr. Opelka as well. It's really not as much the EMRs, it's sort of the health information exchange aspects of it. So I know it's kind of a brain dump, but I appreciate this conversation. It's been great.
Good. Thank you for bringing up that, the crosswalks. Wouldn't it be great if our EHRs in major institutions were connected to registries and shelters, or food banks, or even connection to behavioral services in the community? What could do? Are there models like that we could study that might help integrate the public health aspects with the healthcare system aspects?
Yeah, we can't even get connected to the vaccine registries to help with COVID. It's a challenge.
Let's go next to Vicky Wachino.
Thank you. A couple of reflections on public health and then a few reflections on social determinants. I think the past year has really kind of raised questions about the relationship between healthcare and public health. Neil, you said a few minutes ago that there are models and places where that has worked really well, but I think there are larger questions both about what's the appropriate level of investment in public health, both in emergency and non-emergent times, and then what are the right connections between the healthcare system and the public health system, and are we getting value in the healthcare system from our current relationship with public health? Are we promoting public health interventions? Are we harnessing public health research? And what should be the relationship between healthcare providers and plans and public health? I don't have a point of view on the answers to those questions, but I think there could be a significant research agenda there. On social determinants, it is so welcome that people are recognizing more of the context of people's lives and that it does relate to health. But I think there are questions that haven't been answered yet and merit exploration. One is, the overall evidence base on social determinants and its benefits to health, I think, is still being built, and not all interventions are created equally. And so potentially PCORI could add value there. Who should pay is another question. There is, a tendency, as was noted earlier in the conversation, to encourage payers and providers to pay. That risks over-medicalizing social services and potentially commercializing social services, since we have a healthcare system that's dominated by commercial payers. And I think that there are trade-offs there that need to be explored, both in absolute terms and relative to community investment and the role that community organizations play. And I think if you're looking at social determinants from a community perspective, as I think we should, I think that there are trade-offs for those community-based organizations in working with big payers, and that we should start from a perspective of strengthening that sector of the economy, not weakening it. And then last, I think when we get into social determinants, we tend to go immediately to what services should be paid for. But there's also an element of social determinants where different parts of our different systems come together to affect people's lives. The criminal justice system is clearly one, and law enforcement is clearly one. And so as child welfare system is another, where systems are operating with very different objectives, and they are playing out to affect people's health and people's public safety. But because we never take a step back and look cross-sectorally, or we rarely do, we don't really see those connections. The National Academies actually did a fantastic report this past fall on decarceration in the era of COVID, which is great kind of cross-sectoral work that could be built on to start helping all of us, not just the healthcare sector, but the law enforcement sector, the public safety sector, the child welfare sector, understand how our different policies and procedures are coming together to affect people's lives.
Thank you. Let's go to Beverly Johnson.
Thank you so much. And thank you, Vicki, for taking us back to some of the conversation around public health. I think there's a real opportunity to tap into some learning from long ago related to maternal and child health, and really use that learning to rebuild our public health system. I think focusing on public health is one way to address the health equity issues without just focusing on the healthcare system. And when Surgeon General Koop was the Surgeon General of the United States, and I think of that as he was a wonderful example of a public health leader. there was insistence that families would be partners, full partners in the community assessment process, and in the process to implement the strategies from that community assessment. And I think we need to, and that was followed by work with HIV/AIDS community in the same way, because they knew their community, the strengths and the vulnerabilities. And I think we need to look at the broader healthcare system that's dealing with all aspects and all ages of people and expect the same level of partnership and from the very beginning in terms of what are the needs and the strengths of communities, and how would you address them and build on, address the needs and build on the strengths. I think there's a significant role for PCORI in terms of looking at the various approaches of these partnerships with the, if we don't want to call them patients, which is hard for me not to, I have a very much of an empowerment view of patients, but persons and families of the community, particularly diverse and underserved communities. Look at the research about what are various approaches to effective partnership, where it's meaningful, substantive, where it makes a difference. And so there's both a research agenda here, but a real urging of trying to change and build more robust partnerships at the public health system level. Thank you.
Thank you, Beverly. Why don't we advance to our second question? I think we've, in some sense, begun to address some of these about what it would take for PCORI to fully utilize its research strategies and core competencies to expand patient-centered value. And there's a couple probes that are there. But are there others who would like to comment? Also invite our panelists to come back and offer some thoughts now that they've heard others. Yeah, I thought I saw Larry Levitt. Raise your hand.
Thank you. One thing I would raise that we have not talked much about, I mean, we talked about using price to leverage certain changes. We haven't talked about price or economic burden itself. You know, particularly when we're talking about how the health system treats, you know, vulnerable patients, the idea of the economic burden seems, you know, at least an important thing to raise as a potential part of PCORI's mission.
Yeah, and in fact, that is part of PCORI's mission written into the new legislation is to capture some of the economic aspects, particularly those that are important to patients. So very germane that you bring that up.
And I guess I would just add, I mean, I think when we talk about improving value, we focus a lot on the outcomes or quality end of that. We focus less on the price or economic burden input of that. And obviously either way is a route to improving value.
Thank you. Thank you for bringing that up. Let's see, back to Bruce Siegel.
Hi, thanks, Neil. So looking at anchor question number 2, I would suggest, and I don't know exactly how, but that PCORI does focus on that second bullet, research on new care delivery models. And specifically, I want to call out acute care hospital at home and telehealth, which are not the same thing, but linked. But we've just had, during the course of the pandemic, a really substantial natural experiment, certainly uncontrolled, but an experiment with rapid expansion in hospital at home, which had been studied on a very limited basis before, and dramatic expansions in telehealth across all sorts of health systems, which I suspect is now dropping fairly substantially as time goes by, at least from what I hear anecdotally. And while I realize it's retrospective, I do think understanding the value that these modalities may or may not have provided, as well as the experience that patients had through these modalities, could be extraordinarily valuable. And I think this will also help inform, future policy, payment policy, and other policy, as well as future potential demonstrations of CMMI. But I hate to see the opportunity of having had this natural experiment that's now perhaps tailing off be lost in terms of understanding whether or not these modalities have real potential to add value to healthcare and improve health.
Thank you for bringing that up. An important part of capturing some of the lessons of her recent experience. Let's go back to Dr. Wilkins. Dr. Wilkins.
Yes, thank you. I would certainly endorse Bruce's recommendations for areas of study. I think we also need to be looking at, again, those unintended consequences, negative consequences of telehealth, as well as hospital at home, and how different populations, how people with different lived experiences, cultures, needs, et cetera, are able to adopt and use these new delivery or more recently heavily adopted delivery models. Your ability to use telehealth, a lot of focus has been put on the need for high-speed internet in some communities, and I certainly think that's relevant. But if you have to have a healthcare visit in the break room of your of the retail establishment that you work in, holding your smartphone in front of you and people walking by, is a very different experience than when you are able to set aside time at home and sit in front of your computer to have that healthcare visit. And if we're not actually offering these appointments at times that are more convenient to people, there are lots of nuances that, again, could widen disparities and inequities there. I would also think about ways of testing, again, these incentives or support systems, resources that have been identified as valuable and needed based on people and their families and communities. So if we're talking about managing diabetes, can we actually allow for resources to support people purchasing food in their communities from places that supply the kinds of cultural foods they typically eat and are not restricted to certain settings, as opposed to, again, compared to some other less tailored, culturally tailored or untailored approach to managing their care.
Thank you for bringing particularly that aspect in digital health equity. Let's go to Dr. Hughes.
Thank you again. I was reflecting on Bruce's point as well as Consuela's point, just thinking, and also with even Anand's point that we haven't really talked about COVID, but now we're starting to talk about what are some of the lessons that we're learning through this pandemic. What can we take away? And I'm reflecting on the third bullet, who are our key partners? And I'm thinking, how can PCORI take advantage of the tremendous resources that are flowing to the various sectors and partnering with some of these organizations and some of these entities to better understand what is working in the field, what evidence needs to be generated, what are some of the opportunities to advance these partnerships and collaborations and in the context of health. And if you think about some of the numbers, I think it bears mentioning. I mean, public health received $7.66 billion through ARPA. If you look at childcare, they received $39 billion. If you look at education, they received $122.7 billion. I mean, these are staggering funding streams that have been appropriated by the Congress. And I do think that that provides an opportunity and in some ways an impetus for PCORI and others on the healthcare side to think about how can we work together? What can we learn? What are the opportunities for evidence generation that this moment in time affords us? How do we pivot to address the opportunities that are coming, that are already in the pike, even as we're thinking longer term?
Thank you, Dr. Hughes. Let's go to Akin Demahan.
Thank you, Dr. Poe, and really wonderful and insightful comments have been shared. Just a couple of them that I would reflect on a little bit more. The first is the point that Dr. Siegel raised around taking this wonderful opportunity that the pandemic has presented to study some of these models and understand why they worked, how they worked, what worked the best, what would need to be improved. I think that would be a wonderful area for PCORI to try to take on. The second is, I think, linked back to some of the comments that were raised earlier about data and how one measures health equity, how one shares data about inequities across the system so that multiple parts of the system can actually act on it and use it. I think there is a really great need for understanding what approaches work well and which ones don't. I noticed in the chat, Dr. Apelka was raising a couple of points about sort of building some of those standards and understanding which ones work the most effectively. Data seems to underpin a lot of what folks are hoping to do related to health equity. And I think being able to sketch that out and understand how to make it effective would be an area that PCORI could really fill in a gap on.
Thank you. So let's see, back to Gwen Darian.
Whoops. Okay, here we go. So I just kept on reading this question over and over again, because it takes as a given that we know what this concept of patient-centered value is. And I actually think that's the place to begin, because I don't know if we do know what this concept of patient-centered value is. There are many different concepts depending on where you are in your life, depending on where you live, depending on what your diagnosis is. There's so many different variables in that. And so I think the place to start is to actually think about what the concept of patient-centered value is and to think about defining that. I know that I was very excited that PCORI was able to look at the burdens and financial and economic burdens on patients. Based on the work that we do at Patient Advocate Foundation, the patients that we serve are primarily low income, under-resourced, underinsured patients. And often financial burden is one of the things they fear the most, bankruptcy and financial devastation, often more than the devastation, the outcomes of their disease and their disease and health outcomes. So I think we start by looking at what is this concept of patient-centered value. Thank you.
Thank you for bringing that up. Again, the issue of the economic cost to patients, which can happen both in the healthcare and the health sector that we seek to connect. Are there other comments? I don't know if we've heard this last bullet point on what who the key partners are, but let me call on Rick Rader.
Yeah, thank you. The largest patient population where patient-centered values is shoulder-shrugged, ignored, or invisible of people with disabilities. If you want a canary in the coal mine, they're there. We're talking about cognitive, sensory, mobility, behavioral. And if PCORI wants key partners, including non-traditional partners, I would urge them to seek out parents of children with special healthcare needs. They have seen it all, the good, the bad, and the ugly. And when I'm talking about children with special healthcare needs, we're talking about families where the parents are in their 80s and their children are in their 60s. So it basically is health span and lifespan unique.
Thank you. Thank you for bringing that forward. Other key partners maybe, or others might say? If anyone else. I have your last chance. We have a few more minutes here. I see comments in the chat about the National Library of Medicine being key partner, foundations like the Robert Wood Johnson Foundation, and of course, data exchange organizations, particularly like the Office of the National Coordinator. Okay, I guess we're kind of not any more suggestions. Everybody's put a lot on the table for us to consider. So why don't we then go to trying to summarize what we have here today. So, so here are the things that, just to summarize, that we've tried to capture. Regarding question one about how do we create a patient-centered learning health system, what we heard that we need clarity about whether the emphasis is on health equity or health care equity, because they might take different approaches based on that determination. I would also say that we heard it is how do we integrate those? And another thing we've heard, we have an opportunity for cross-sector learning as a consequence of COVID, which revealed vulnerabilities in the system, including public health, but also showed us some of the strengths that can be joined together at the system, individual and community level. And, you know, how can we use those strengths to address the regular healthcare and not just in a pandemic. So PCORI has the opportunity to study those partnerships and assess what's working and what levers might lead to change or be harvested from our past experience. Next. And then this is on question 2 about patient-centered value in health care. We had a discussion about value and how that tends to focus more on the outputs than the inputs. And we need a PCORI focus on studying new care models, such as acute care health at home and telehealth. We've had a lot of uncontrolled experiments that we could look back at and understand what did these modalities provide, and what were patients' experience with that. And we heard it looking at the unintended consequences and how different lived experience, cultures, needs influence adoption or not adoption of technology. Ability to use telehealth is dependent on broadband, but if you're taking a healthcare visit, you know, when you have to work during the day and it's not, the time is not accessible, it's a different experience than just sitting home in front of a computer. So we need to think about patient convenience and nuances that contribute to those disparities, kind of giving patients what they need. We also need to test the systems of support that have been put in place and look at culturally tailored approaches to digital health equity. We heard, how can PCORI partner in advanced collaboration? Public health receives a large amount of money, and you know, how can we what opportunity is there to put the different funding streams together to learn together? People reflected on the opportunity presented to COVID to understand what worked about the models that we had in place and where we can improve. And we heard about early comments about the data about measuring health equity and how we can act on the data. It's a great need for understanding the opportunity to learn from standards, which ones work, which don't. And we learned that data underpin effectiveness, and PCORI might have a role in filling that gap. Gwen brought up the question, it takes as a given that we know what the concept of patient-centered value is, but maybe we don't yet, or at least we don't consider it from different perspectives. It's fluid and dependent on many different variables over the lifespan of individuals who suffer health events. And understanding value and burden is a huge leap forward for PCORI. So maybe we can go back and start with that concept of value. And lastly, we heard about people with disabilities, not overlooking people with different types of disabilities, particularly looking at the parents of children with special health care needs and adult children, you know, at the other spectrum. So it's kind of the microcosm of health and healthcare. So really rich discussion, and we really appreciate all the views that we heard today. This, I have to say, was a deeper dive, I think, into some specifics that will help inform PCORI's strategic plan going forward. So I want to give hats off to all of you as participants who provided such a rich discussion, and remind people who put comments in the chat that those will be assimilated into the information distilled from this meeting. So I'm going to turn this back over to Dr. Cook and Dr. McGinnis for some final remarks.
Thank you very much, Neil, for your masterful orchestration and for this very helpful summary. Let me turn to Nikayla to offer her initial reactions.
Thank you so much, Michael, and Neil as well. And on behalf of PCORI's Board of Governors and our Strategic Planning Committee and all the staff at PCORI, I just really want to thank everyone, the presenters and the facilitators and the panelists and attendees, for your participation in what it was a truly an important meeting and incredibly informative. And I want to give a very special thank you to our meeting chair, Dr. Neil Poe, for his outstanding facilitation today. And we're excited actually by the opportunity to explore a lot of these insightful points that were raised today related to the opportunities and challenges on the health horizon and the unique role that PCORI can play given its mission and funding. And I was particularly struck by the comments about building relationships and connectors to effectuate impact, and doing that as we consider learning health systems that are underpinned by achievement of health equity, as well as the data and digital infrastructure that's attentive to not perpetuating unintended consequences in certain communities. And I believe the discussions also are going to greatly inform PCORI's efforts as we continue to forge our path forward in terms of continuing to think about how we ensure patients and the public have the information they can use to make decisions that reflect their desired health outcomes. And I reflected quite a bit on the dialogue about patient-centeredness and person-centeredness and how those two really do have to come together in our work. And as I mentioned earlier, the invaluable input that was gathered is going to be summarized and provided to PCORI's Board of Governors as we continue our discussions about identifying our national priorities for health, as well as our research agenda and our final strategic plan, which will come together toward the end of this year. And I also mentioned in the chat, and hopefully for all of you to know, that this is an ongoing dialogue and discussion, and there will be many more opportunities to provide comment. And if you haven't done so, please go to our website at PCORI.org and sign up for updates. Our weekly emails will keep you alerted to when the comment periods are available and open for your continued engagement. And additionally, I wanted to mention that a small work group of the attendees at the meeting today and at the meeting, the prior meeting that occurred as part of the Priorities on the Health Horizon series, are going to be convened to draft a summary report and publication from this work. And so we'll have the opportunity to really have a product that we can reflect back on as we think about strategic planning and may be informative in your work as well. So this is, again, one of several important opportunities to garner broad insights, and I am so grateful and appreciative for all of your contributions, and want to thank those who listened in for their time, and I think it was probably as informative for them as it was for PCORI, and I look forward to continually collaboratively thinking about how we shape PCORI's future. And Dr. McGinnis, I'll turn it back to you to close the meeting. Thank you so much.
Thank you very much, Nikayla, and thanks to each and every one of you who participated so robustly in this conversation, which from our perspective in the National Academy of Medicine and our partnership perspective with PCORI has been extremely productive in terms of providing information and perspectives and mandates in many ways that can be collected and assembled, analyzed, and made available to PCORI and Dr. Cook as they move together on their strategic plan. You know, in reflecting the comments at the outset about the reauthorization of PCORI and the introduction of new elements into the charge to the organization, and in particular, its metamorphosis into an organization that began in many ways with a focus on head-to-head assessments of different kinds of interventions. At least that was some of the motivational discussion around the creation of PCORI, to one which is now, especially with the introduction of formally of the value dimension, is an exciting new focus that comes with uncertainties in each element of the value equation. That is, what kinds of outcomes are we talking about? What are the costs involved? Some of them are monetary, some of them are personal in nature. What are the sources of revenues to bear those costs, and what is the nature of the burden of the costs involved? Essentially, PCORI has taken on in its new mandate a fundamentally integrative perspective, and that is the charge, which is complicated but vitally important if we're dealing with the realities of the world today, to look across all key elements in the health equation. What happens inside the clinic doors, the strength of the community, the balance between strong community organizations and the source of revenues that's are channeled to support in different ways, the role of public health, the nature of accountability, the notion of data as a core utility for advancement across the board. How to understand what people really care about in families, what makes the most difference. In each, issue number one for PCORI is in some ways to identify what are those key elements in the health equation, and followed closely on by the challenge of understanding the uncertainties in the way that those elements play out, identifying them and stacking them up against PCORI's opportunities to help resolve those uncertainties. It's a very exciting agenda. It certainly is critical. There's no national organization that has that kind of integrative mandate for better health than we see in PCORI. The working group that Dr. Cook mentioned is got a sizable task to do, but it's well armed, well equipped with the diverse and productive nature of the comments throughout the course of today and the previous day. And I should mention that as Dr. Cook indicated, the ledger is open, not only in the comments that will be collated and assessed from the chat, but other questions or suggestions that you have along the way as the working group takes on its challenge of and activity of developing the synthesis and the consolidated report that will serve as a resource clearly to PCORI, a touchstone reference point, along with the many other sources of input that they're inviting from their outreach to the nation and also to the field. The work of the consolidated report will hopefully be a long-standing resource for folks, and we'll look forward to how that plays out. Even those of us who are involved in its production will look forward to that. I want to close with obviously a heartfelt thanks to our colleagues in PCORI, Jean Slutsky, Laura Lyman Rodriguez, Kat Jackstadt, and of course, Nikayla Cook for this wonderful partnership. And from the National Academy of Medicine side, Ariana Bailey, Mike Cocciola, Ayadola Nishe, and Sarah Green. Sarah, I have to offer a special note of applause and thanks to the wonderful work that you have done and are doing on this project. And I'll say, save the strongest note of awe-inspiring performance for Neil Poe, who has been a masterful partner throughout. And so to all of you, to be continued on all counts. Meanwhile, thank you very much.